The socio-ecological model's purpose is to recognize that individuals both affect and are affected by a variety of social influences and environmental interactions. CDC 2020. And use of this knowledge gained from these influences and interactions can help shed light on a vast array of target topics for health promotion. Through this model of health promotion, the relationship between individuals and society factors is assessed to determine factors that promote or inhibit well-being. Smith and Parker 2020. Implementation of the socio-ecological model could potentially address the barriers that affect parental adherence to safe sleep practices and understand how to promote safer sleep for infants. The socio-ecological model recognizes barriers that influence and are influenced by behaviors. Psalm Ward et al. 2021. With regards to safe sleep practices, this model suggests that multiple factors contribute to the behavior of safe sleep, including infant, maternal, cultural, and community society levels. Psalm Ward et al. 2021. The first article that I used for an intervention strategy is from Hodges et al. 2017. All of the following information is from that source. Obstetricians during prenatal visits might be the woman's only source of prenatal care before birth. However, only 55% of physicians thought it was important to include the topic of safe sleep during these visits. The article determined that 82%, however, were interested in bringing up the topic, but lack of resources or time made it impossible. However, these physicians can influence decisions that women make regarding safe sleep with their infants during these prenatal visits. This indicates that education should be provided to physicians and nursing staff, as well as allotted necessary time in order to properly educate their patients regarding safe sleep. The next article, Shanahan et al. 2021, focused on interventions of home visits to provide families with education about infant safe sleep guidelines and to help cope with the many barriers families face regarding their engagement in safe sleep practices. The article focused on motivational interviewing and cultural sensitivity during the home visits. When determining barriers, they found similar ones that I identified in the conceptual model, including concerns about choking, sleep quality, disbelief about risk for infant death, perceived inconvenience of recommendations, and conflicting messages from family members were barriers to safe sleep practices. The study results provide preliminary evidence that training home visitors in use of MI techniques and safe sleep conversations could have a positive impact on clients' willingness to engage in behavioral change. But they also noted that repeated discussions will be required to help clients make the decision to engage in behavioral change. In a randomized control trial by Lutenberg et al., Maternal Infant Health Outreach Program, which was a home visiting program, was compared to a minimal education intervention group. Patients were seen from 28 weeks of gestation until 6 months postpartum. Results showed that patients in the outreach education program, which was the home visit program, reported positioning their infant on their back much more often than parents in the other group, which was 98% compared to 66%. Additionally, the parents in the intervention group reported way less occurrences of co-sleeping than the other group. The next intervention is from an article written by Eller Schmidt et al. 2019. The article was based on the implementation of a statewide program to promote safe sleep through what they called community-led baby showers. These baby showers included information on safe sleep promotion to pregnant women with low socioeconomic status. Significant increases in knowledge about safe sleep guidelines were seen from the pre-test into the post-test, and a significant number of participants reported a plan to follow the AAP safe sleep guideline. The linkages between question, problem, issue, theory, and strategies. The biggest linkage between the clinical question, theory, and strategies were barriers. Unsafe sleep habits occur due to barriers faced by parents with infants, which is highlighted and broken down into categories by the socio-ecological theory. The theory aimed to encourage safe sleep practices, targets the barrier of care faced by parents with focus on education and available resources. Parents who practice unsafe sleep habits with their newborn may be conceptualized using the socio-ecological theory, providing education to parents about safe sleep practices during prenatal care, before discharge, and during follow-up appointments, as well as providing parents with resources like social work or home health educational visits, may lead to an improved outcome of care as evidenced by engagement in safer sleep practices. The socio-ecological theory is centered around four main concepts: individual, relationship, community, and society. The diagram from the CDC shows how overlapping rings signify the factors on one level influence factors on another level. My conceptual model included the following. Individual factors were seen as maternal age, gestational age, birth weight, substance abuse, infant's preference towards best sleeping position, and race and culture of the mom. The relationship category included marital status, social support, race and culture of partners, or major social support. Community concepts included prenatal care, prenatal education, income, residence type, with specifically the number of rooms in the household. Society factors included access to education and services for care, poverty level, and misconceptions or beliefs regarding sleep positions. The following is the conclusion implication for nursing practice. Appropriateness of the selected theory. Through research, I found the social ecological theory was appropriate in explaining my clinical problem of parents still engaging in unsafe sleep practices with their newborns. The four main concepts of individual factors, relationship, community, and society all fit well with my concept. I found that the concept of relationship and community encompass the majority of the barriers parents face when engaging in unsafe sleep practices, according to the research that I conducted. Nearly all of the research articles I viewed or used throughout the process indicated that infant mortality continues to remain a problem in the United States, and that a significant portion is due from sleep-related deaths. Elhemers, Schmidt et al., 2019. There was an extremely high quality of evidence that supported my question. However, the quality of evidence for intervention was not as high. I struggled to find articles that were from the past 5 years. I also found it difficult to find articles that examined the results after education, seminars, or discharge teaching took place, and then how it affected the parents' sleeping decisions. Instead, I found a lot of information regarding education for healthcare professionals in order to ensure a uniform and up-to-date approach regarding safe sleep practices during prenatal or pediatric appointments. I did find a few conflicting findings regarding safe sleep education and its impact on parents' behavioral changes to follow the safe sleep guidelines. Often this was due to barriers described in my conceptual model. Implication for nursing. Nurses and providers play a significant role in both educating and modeling safe sleep practices for patients and parents and infants. Implications for nursing practice would include continuous and proper education regarding safe sleep habits for newborns, modeling and reinforcing safe sleep practices with proper resources and home health services if necessary. Additionally, implications for nursing practice should also include holding community educational opportunities for pregnant women regarding safe sleep guidelines and recommendations. I would recommend practice change to include more time during prenatal visits and discharge education where parents can discuss barriers to engage in safe sleep practices, which can prompt additional resources for them. One of the things that I thought would be a good addition was a possible screening in the electronic medical record either when patients are admitted for like going into labor or during prenatal visits, where there would be boxes based on the social ecological theory of all of the barriers to care, where nurses could select certain barriers that they felt the patients like fit the patient's health history or their prenatal care or their socioeconomic status. And then based off of the answers that the nurses would give on this screening, they would be prompted either to give the patient more additional resources or a lot more time to discuss safe sleep habits, or they would be prompted that the patient is adequate in their knowledge and like had a good understanding and would be more willing to engage in safe sleep practices. This raises the question of how to address certain barriers patients face specific to engaging in safe sleep practices and what resources we can provide to help increase safe sleep. This is from Chanahan et al. 2021. They found that motivational interviewing and cultural sensitivity to be possible answers to this question, but more research needs to be done to confirm these results.